So thank you, Andrea and Stephen. It's a really pleasure to discuss with you at the beginning of this World Federation Congress. And I will start with, I will go immediately with my disclosure, of course. And I will start with a very general sentence. So von Willebrand disease is a disease and we need bleeding. It's exactly the same as we have hemophilia. And we don't want to think about hemophilia if we don't see patients, young patients with bleeding. So I think one of the major points I would like to address today, since we want to have a disease and we want to assess bleeding, how do we assess correctly the bleeding? And following the presentation of Francesca and Imre, it's much easier for me to focus most of my presentation on how the correct bleeding history collected with appropriate questionnaire will help us to give an appropriate diagnostic of severity of von Willebrand disease. So general statements, I believe everybody knows that von Willebrand disease is due to quantitative or qualitative defect. And severe forms are mainly related to the low activity of the von Willebrand factor. And in some of these conditions, we have also very low level of factor VIII. So we have to consider also factor VIII. So as we discussed in the previous two presentations, despite the fact that there are many activities of von Willebrand factor into the circulation differently from factor VIII, since factor VIII is mainly devoted on coagulation, so it's much easier to do assay on factor VIII. We need the PTT, factor VIII. For us, it's little for people working, for investigator working and scientists, and also physician working on von Willebrand disease, it's really more difficult to make a correct diagnosis. But if we think about the patients and the appropriate approach we would like to give to our patients, what is really important, despite the fact that molecular biology helps to make diagnosis, classification is important, but my approach to patients and to clinicians today is a little more simple. In other words, we should provide a sort of a clinical approach, putting together assessment of the clinical bleeding together with a very simple approach in the lab test. As Francesca pointed out, we have three criteria: bleeding history, low von Willebrand factor activity, mainly devoted in the central part of the von Willebrand factor molecule, and inheritance. But we also to deal with the fact that we have heterogeneity, especially if we check what we call retrospective studies in registry. And sometimes we are still facing the problem on whether or not we are able to distinguish between low level and patients with von Willebrand disease. So this is something that we usually are dealing with every day. Which are the challenges? As I said, I'll repeat more or less what the two presenters show us. So we have a complex abnormality of von Willebrand factor in VWD patients, several modifier and physiological levels, and lack of single laboratory test to identify VWD patients. And this is exactly the same situation. We have a basic test, specific test, additional test, and I don't want to repeat what Imre was presented, but I had to put these two slides, and so for me it's very quick presentation because I already explained all these issues about also the gain of function mutant GPOAB binding assay for von Willebrand factor activity. So this is the classification published by the group of colleagues in the United States, and gives you immediately the classification, so I don't want to go into details. But If we want to reproduce in the clinical practice this classification in the everyday approach to our patients, certainly we do need bleeding assessment tools. And to comment on the bleeding assessment tool, this is my first part, and then I will conclude with an example of how putting together very good assessment of the bleeding tendency together with a simplified approach on von Willebrand factor activity and factor VIII activity, we probably end up with good outcomes on risk of bleeding in our patients. But let's start with this recent commentary by Alberto Tosetto. Alberto Tosetto and the group of Vicenza made a major improvement in the bleeding assessment tools. And this is the first slide where it shows that even you consider normal population, there are large possibility that normal population, non-von Willebrand disease population, can present with, different bleeding episodes. We have Andra, so she knows very well that menorrhagia cannot be always present in von Willebrand disease. There are other conditions where menorrhagia is present, for instance. The first template, Alberto, together with Francesco Rodeguiero, was this one, and this is the first template. This was, as you can see, epistaxis, several, without any specific numbering. The second template was considered in the MCM-DM European study. It was also applied for the Canadian study and the UK studies in Type 1 von Willebrand disease. But the most recent and the assessment tool that for bleeding that we are now following is the assessment tool proposed by STH recently. And this is, I would like to comment, that is all these kind of symptoms can be scored according to specific intensity of the bleeding found very carefully following a very, of the presentation of very important and very detailed questionnaire. So, I would like to discuss one of the most recent design of the study as an example where we would like to put together assays, and this is a type 3, so it's a very simple assay, together with the bleeding score to assess in a prospective way how many times this kind of type 3 patients would like to do. As you can see, we have the Twinwinters IPS project is mainly devoted to type 3. We have Iranian and European patients. We enroll with the bleeding history, and the bleeding history at the beginning, the retrospective phase, was analyzed by the second template, that the same as we were using for type 1 von Willebrand disease. But now, in the second part, the prospective phase, we are doing the new BOT. Why we would like to do this? Because we want to make comparison in a prospective way is on whether or not specific mutations, specific levels, even very low level of von Willebrand factor in type 3 can be important to assess the frequency of the von Willebrand disease, of the bleeding in von Willebrand disease, also in type 3, that is considered the most severe form. Why we would like to do this? Because if we want to address again the endogenous assessment for the von Willebrand factor, we have another tool. Is the Ddp Infusion Trial. Because with the Ddp Infusion Trial, we can measure how the endogenous von Willebrand factor present in several forms of von Willebrand disease can react to the physiological or paraphysiological stimuli induced by the DAVP. So you can tell very easily that there are responsive and non-responsive patients after the DAVP. And also we have a challenge test that gives you a very large variability also in type 1. So if we put together, so this is an update for flowchart for VWD diagnosis used in Italian registry right now. So since we want to put together all this assay with the DDABP, certainly by using these criteria, by putting baseline level and to repeat the baseline level after DDABP, certainly we can have more information, practical information on how von Willebrand patients can respond to endogenous and probably finding who are the patients who will benefit on exogenous von Willebrand factor concentrate. Why we are happy with that? Because in the last 10 years we have been using a prospective approach in Italian registry called RENAVI, and we found that the bleeding score predicts clinical outcome and replacement therapy in at least adult patients with von Willebrand disease. Why this occurs? Because we could correlate very well the bleeding score with the level of activity. In this case, was histocytic factor, but I'm quite sure that we'll have the same result by using the new assays. As you can see, we have a very pretty good correlation with the level and bleeding score. Since we have a 3.5, when it's corresponding to the 30% of histocytic factor activity. And the more is the bleeding score, is the higher the probability to have a bleeding in this kind of patients. Look at this bleeding event survival curves. You see that as we can expect, we have several forms of mild, moderate, and severe type 1, but what was not expected that we could find different type of bleeding event survival also in type 3. And which are the bleeding phenotypes in von Willebrand disease type 3 according to the different colors represented the different types? You see the most important aspect that all of them, they can share mucosal bleeding, but GI bleeding is completely more present in a patient with type 3 and a type 2A, where we have a loss of multimers, and hematomas and joint bleeding can be present only in type 3, where the factor VIII is very low. This approach is not only important to understand the baseline severity of the patients. If we follow correctly the bleeding assessment tool in this patient, we can probably predict how many times this patient can be treated. As you can see, with the bleeding score more than 10, this patient received more DDAVP, and also they could receive more concentrate independently of the type. You see that in this prospective study, patient with type 1 more than 10 bleeding score received equal amount of concentrate in 1 year time as those with type 3, that are patients who are considered the most severe forms. So the conclusion of RENAVI, where the bleeding score correlates with von Willebrand factor level in VWD and helps to predict clinical outcome, at least in adult patients with VWD. And so my message today for you is that if we can base our evaluation of the evaluation of our patients in terms of clinical aspects with a very good tool like a bleeding assessment tool, if we can test very reliable assay like what was presented by Imre Bodo as a platelet-dependent von Willebrand factor activity, we certainly can improve in every lab, in every country, the diagnosis of VWD patients. Even my suggestion is also that if we also put the DDAVP challenge test at the time of diagnosis, we can also improve this individual and correct approach. Thank you for your attention.